Okay, class, welcome back. In this unit, we'll get into classifications of blood pressure. So, in terms of how we diagnose things. Hypertension overall is subdivided into two general categories. There is essential hypertension, which is a vast majority of cases, which we think is an interaction, right, between environmental factors, genetics. There's no particular known cause, right? Could be a combination of multiple different things: obesity, a little bit of diabetes, a little bit of inactivity, a little bit of stress, poor sleep, right? That's the vast majority of cases. That's what we call essential hypertension. Now, there is also secondary hypertension, which is just like pretty much every diagnosis which uses this term. Secondary means it's secondary to some, known condition, right? So you could have, secondary hypertension, secondary to an acute change in your kidney function of some nature, or an acute change in the vascular structure. So that's secondary to something else. That's a little bit rarer. Now, in terms of causes and contributors, we mentioned some of the big ones, right? Especially where we really have a role here: inactivity, right? Obesity, are big ones. There's also diet, right? We think salt sensitivity as well may play a role with that. If you're actually interested, there's a fantastic researcher, a colleague of mine named Austin Robinson, as a PhD scientist. He's now, I believe, at Auburn University. As a lot of his work is looking at salt sensitivity and how that may particularly affect, the diagnosis and progression of hypertension. We also know, anything, that's going to affect sleep. So sleep apnea is a big one. We talked about that in our sleep health lecture and health promotion. Sleep is, can lead to, or poor sleep can lead to even acutely elevated, one night's disturbance can raise blood pressure. We think that's driven by the sympathetic nervous system, but really anything that's going to increase sympathetic nervous system activity is going to raise blood pressure. Recreational drugs and alcohol, binge drinking, which is a big problem in the youths, right? We talked about what we're seeing upstream, looking at kids, right? The big concern, of course, is diabetes, obesity, and activity. But in college-age students, right, or 18 to 25-year-old demographics, binge drinking is a massive concern, and there's a very strong association with that, and blood pressure. Whether we think there may be some connections or benefits of maybe moderate alcohol intake, that's even questionable depending on the type, especially red wine versus maybe whiskeys or something of that nature. But binge drinking, having large quantities, I believe it's 6 in a night, is a big concern, and again may lead to downstream changes in terms of looking at vascular health. Now, this is a big change here, right? So our blood pressure categories, this change in 2017, I remember when this first came out, it happened in the middle of my lecture, a few years ago. Now, the normal values have not changed, right? Normal systolic blood pressure is still 100 to 120. That has not changed, okay? Which gives you a pretty wide range of normal. And it's interesting, we always ask patients, most people, what's your normal blood pressure? And most people end up just saying 120 over 80. That's actually borderline, even by the old classifications. Diastolic, 60 to 80. And then mean pressure should be between about 70 to 100. The minimum for organ perfusion, if you remember that, autoregulation curve slide, 60. So if you start going below that, then we start having some problems. If you want to remember how to calculate mean arterial pressure, again, it's 2 times diastolic plus systolic divided by 3. And we do that because diastole, we're in for twice as long as systole. So diastole counts twice as much as systole to our blood pressure over the mean, over the average, or the average of the cardiac cycle. So we do 2, the diastolic, plus 1 systolic value over 3. Right, so that would be how we get mean arterial pressure. And I've got it in the slides, a calculator, if you really just want to remember it, but that's how we do it. And it's also just kind of a good point to remember from physiology that our diastolic pressure really is what drives our mean pressure, and that's kind of like often what our heart's working against in a certain sense. So we start seeing big changes in this, we can have some serious impact on blood pressure, right, and disease. Now, the blood pressure categories, right? Again, we said the normal cutoff still has not changed, right? It's still less than 120, less than an 80, and there's really no, again, except for means below 60, and even then, that's a little bit of a gray area. There's no well-established cutoff for hypotension. It's by symptoms, because you can have some people with blood pressures in the 90s and they're completely fine. It's based off of symptoms. So hypotension or blood pressure being too low, it's, again, if it's below 60 mean, that's a pretty good indicator. They're probably not perfusing super well. But for most people, we're just going to base it off of their symptoms. And again, don't be too shocked that someone's pressure is below 100 systolic or below 60 diastolic and they're asymptomatic. Now, what changed is our typical blood pressure cutoffs started at 140 systolic and 90 diastolic. That changed, right? So now, and pre-hypertensive was anyone just above 120 all the way up to 140. So that's changed now, and we don't even use the term pre-hypertension, we use the term elevated. So anyone between 120 to 129, elevated, right? So not normal, and less than 80. So we're not seeing wholesale change in diastolic yet. Diastolic still normal. Their systolic's a little bit up, called elevated. Hypertension now, instead of being 140 systolic, we're calling that anything above 130. Someone is diagnosed as hypertensive. Or their diastolic has creeped up above 80. That's a big change, because it used to be 140 over 90 was our cutoff, and now it's 130 or up or above 80. Which kind of goes to show you how much, again, a change in diastolic can really matter. But 130 or above, you're in hypertension stage 1, or, so either or, a diastolic above 80. Hypertension stage 2, 140 or higher, or 90 or higher. And again, back in the day, this used to be stage 1. So we've shifted things up a little bit, and I'll explain why this happened in a bit. And then hypertensive crises is anyone higher than 180 systolic and or, so either or, higher than 120 diastolic. Okay? So that's when we start getting into this patient is not medically stable, and we'll get into what we can do when we encounter that in a bit. Now, in terms of normal interarm differences, you shouldn't see much of a difference between arms, at most 10 millimeters of mercury. They should be pretty close to the same. Now, the reason why these values changed has a lot to do with this landmark study here, the SPRINT trial, okay, which was published in the New England Journal of Medicine in 2015, which demonstrated that a more aggressive blood pressure goal of 120, again, typically it had been 140 standard treatment. If we made it more aggressive, mortality rates went down significantly, and there wasn't much. There were some adverse events. However, they were kind of minor, right? It was like, it was orthostasis, right? There wasn't really a significant impact on mortality. And that really, as well as the body of evidence showing that even if you have a blood pressure above 125, honestly, it's predictive of future adverse or untoward events. So it was a huge landmark study that led to a fundamental change in how we view blood pressure and how we classify it. Now there was some controversy, and there's still some controversy over this. The JNC guidelines, which are the Joint National Commission, which is a combination of different societies that help set different guidelines, actually recommended that for older populations it should be a little bit higher. It should still be that 140 range, roughly. And their thought process is that there are some normal age-related changes to blood pressure, and again, like we talked about, if you have a higher blood pressure and you're your baroreceptor and your body systems get used to that set point. Lowering it too quickly, those feedback loops, those regulatory systems may not be as responsive and could lead to complications. There is still some controversy in cardiology circles about, are we going too low or being too aggressive? But again, the AHA, which is our national regulatory body for cardiology or heart health, and the American College of Cardiology are going with these guidelines now. Again, these are newer changes, happened a few years ago. Now, other point of controversy will as well, are we over medicalizing people now, right? Because again, the old classifications were this, right? And now we're at this, and we've moved some people that were pre-hypertensive who might not have been medicated, right, or medicalized or diagnosed as hypertensive into being diagnosed as hypertensive. Are we going to rush to put these people into pharmacological therapies? Now, again, point of controversy, but if you look at the guidelines, which people are supposed to be following, what do you see? You see the first recommendation, even for these patients, is still non-pharmacological therapy, lifestyle interventions. And realistically, if we looked at the percentage of patients that moved in this classification that were, it wasn't a large number of patients who ended up being medicated, right? Because it was really only patients who would need medication would be at a high risk of strokes. Their ACSD scores were super high. And that was I think 4% of patients. It wasn't a large number. And again, those patients should be medicated. But there is, again, coming from medicine, a call to try to get these patients enrolled. And that was the thought process too. If we can get them diagnosed, and we know even with a pressure above 125, that's not a good situation to be in. We can get them enrolled into if we can get them diagnosed, get them into the medical system, to get enrolled maybe in a lifestyle program, non-pharmacological therapy to lower their blood pressure, right? We can maybe treat this earlier before it becomes a bigger problem. The problem is there aren't cardiac rehab facilities everywhere, and I actually think our role as a profession could really be interceding here, right? Working with those patients with stage 1 or even stage 2 hypertension that are at lower risk, right? That we could maybe intervene with some blood pressure or blood pressure lowering programs through exercise, sleep counseling, and maybe even a little bit of nutrition counseling. And I think we have a big role here because we're already seeing these patients in our clinics, as we've demonstrated by the survey studies I've conducted and the research of Starina and many others. Now, pulse pressure is another one that we see as a classification. Pulse pressure is systolic pressure minus diastolic pressure. Normally, this should be about 40 to 60. Typically, when we have a very low pulse pressure, whenever our systolic and diastolic are super close, we may be losing the ability to have driving pressure to get blood pressure downstream. Right? Remember, diastolic pressure is a pressure remaining in the vessel during relaxation when there isn't a forward pressure wave coming through. If that's kind of high, right, or higher, and our systolic blood pressure is lower, right, if they're getting closer and closer to each other, the ability for that pressure wave to move downstream is going to be decreased, right, because you have to have a gradient. So that's not a good sign. That's indicated, I think we call pulse narrowing when systolic, and diastolic get closer. Either, diastolic's not changing and systolic is decreasing, or both are, changing. So diastolic's increasing and systolic's decreasing. We see this often in heart failure patients going into cardiogenic shock. Elevated would be a concern as well because we have very large fluctuations between systolic and diastolic. It may put a stress on the microcirculatory system. So if you're going through these large fluctuations, right? If your pressure is 180, over 60, that's a difference of 120, right? You're going very large phases. If you're doing that for a prolonged period of time, that can cause some damage in the vessels. Large fluctuations of pressure. And again, hypotension, we talked about this, it's really as low as you can go without symptoms, right? So we classify this typically of a systolic blood pressure below 90 or a diastolic below 60 or a mean pressure below 70. We only start getting absolutely concerned just by numbers alone if mean pressure goes below 60, because we know what that looks like, remembering on that autoregulation curve. Right? If we start getting to that 60 range, we see a sharp drop-off in perfusion to organs, most notably the brain. Right? We go blood flow, pressure. Right? That's an R, that's a P. There we go. We start seeing a sharp drop-off in blood flow. A lot of things can cause hypotension if we lose blood volume. So if you're hemorrhaging, dehydration, cardiogenic insufficiency, so heart failure, inadequate pumping performance, really anything that's going to affect those factors that influence blood pressure, right? Remembering that slide with David Bowie on there. Acute myocardial infarction, same thing, because it's going to, if your heart is having a heart attack, you're going to be losing pumping performance. Antihypertensive medications will lower it as well. Again, generally only a concern if someone has symptoms, right? Asymptomatic hypertension, not a concern, unless we're in those means below 60. But otherwise, we're going to go by symptoms. Now, hypertensive crises, different story. Hypertensive crises is actually fairly common. It's at 25% of all medical emergencies in general. And there's two subgroupings of them, right? Remember, we go to this, chart here. We're in this, hypertensive crises. Now, hypertensive crises are in two groupings, urgencies and emergencies. Again, hypertensive urgencies are people in a critical pressure. So it's blood pressure is either over 180 systolic or 120 diastolic, but they're not showing any signs of organ damage, right? So the pressures are super high, but they don't show signs that they're in an acute medical emergency, right? Like they're having a heart attack or a stroke or something of that nature. Whereas hypertensive emergencies are it's a medical emergency, right? So they've got a critical pressure, again, systolic, either systolic over 180 or diastolic over 120, and they are showing signs of organ damage, so chest pain, shortness of breath, stroke-like symptoms. And again, hypertensive urgencies would just be the opposite. They may have a little bit of headache, they may have a little bit of shortness of breath, but quite often, again, they may not have any symptoms. So again, critical hypertensions can be almost asymptomatic, so we can't just go by symptoms. And again, if they are showing symptoms with a critical blood pressure, that's a medical emergency. And that goes to, and that's the reason for that is, again, explained by this autoregulation curve. If we start getting pressure is super high, which drives up our mean pressure, we're going to be approaching that range where we're unable to prevent that pulsatile flow getting into the microvascular. Because if you remember, it's basic math, mean arterial pressure, right, for someone with a critical blood pressure would correspond to a mean of about 140. So if we start getting beyond 140, we're moving in that range where we're flooding those end organs with too much blood, too much energy, causing damage. That's why we can see acute pulmonary edema, because higher filtration pressures in the lungs causing fluid to fill into the lungs and making it harder to breathe. Left ventricular dysfunction, coronary artery syndrome, right, including MI. It's really hard for the heart to work when pressures are that high. Cerebral infarctions, hypertensive encephalopathy. And then we can, in very high situations, we can even see acute hypertensive nephroscoliosis, which causes, again, little fractures almost, and damage to the small blood vessels in the kidneys. And really, there's several different things that can cause blood in the urine, hematuria. Like none of them are good. But if you see that in a patient with a critical blood pressure, that's a very serious concern. So again, hypertensive crises, two categories, urgencies. They've got a high elevated blood pressure. Probably more a call to the PCP. It's not a 911 call because they're not, their pressure is super high, not appropriate for rehab. But they need to be, maybe have their medications adjusted that day. Someone with a hypertensive emergency where they're showing those symptoms or signs with a critical blood pressure over 180, medical emergency 911 call. So that ends our section on classifications. And next we'll get into some technical issues with blood pressure measurement.